Psych Sessions, episode number 38, Disruptive Behavior Disorders. Hey everybody, it's Jimmy Morris. Welcome to today's session. As I was thinking about who I wanted to discuss today's topic with me, I could think of no one better than Dr. Gathing. After completing medical school, Dr. Gathing further specialized in child and adolescent psychiatry in a fellowship in 2009 to follow her dream to work with children with severe mental illnesses and become an expert in building healthy families. She's not only a board-certified child, adolescent, and adult psychiatrist, she's an author, humanitarian, wife, loving family member, and my friend. Dr. Gathing, welcome to the show.
Thank you. Thanks for having me.
Absolutely. As I've worked with those who have experienced a disruptive behavior disorder or even a family member, a caregiver who knows someone who is struggling with a disruptive behavior disorder, we see how this can have such a profound impact not only on the individual, on the child, with regard to their emotional development, their ability to be able to progress in learning in school, but in other social settings as well, and of course their daily functioning. So I'm glad I have the opportunity to be able to produce this session for my listeners. And as we prepare to discuss these things in detail, please go ahead and start by sharing a little bit with us about your background and your training.
Sure. Well, I am a child, adolescent, and adult psychiatrist, and my area of interest is forensic psychiatry. So I generally work with juveniles in detention centers or long-term treatment centers that have been involved with the legal system. And in my training, I went to the Morehouse School of Medicine for medical school and Emory University School of Medicine for residency as well as fellowship. And I did a fellowship in child and adolescent psychiatry. So I am board certified in child and adolescent as well as adult psychiatry.
Excellent. And your practice is currently in the Dallas-Fort Worth area, is that right?
Currently, yes, I'm in the Dallas-Fort Worth area working with Parkland Health and Hospital System as they run the Juvenile Detention Center Medical. So they do the medicine as well as behavioral health for the Juvenile Detention Center in Dallas County.
Well, I sincerely appreciate the important work that you're doing with our youth. It's not easy to be a youth today, or a parent, or a caregiver for that matter. And as we talk about this, we recognize how it can be of such great benefit for all of us. So let's go ahead and build a great foundation upon a clarification on what we mean when we use the term disruptive disorders.
So disruptive disorders are basically syndromes, so descriptors of behavior that are pathognomonic for a syndrome that are generally diagnosed in childhood, and they involve problems in self-control of behavior and emotions. So these are basically disorders where the children or adolescents have issues with regulating their behavior and regulating their emotions, and that manifests in significant conflict with societal norms or authority figures, or that may lead them to have issues with violating the rights of others. So disruptive disorders are really disorders of behavior and emotional regulation.
Yes, and as we establish this definition, I'm reminded of Psych Sessions episode 36, where I talk about bullying. And it's not to say that all bullies have a disruptive behavior disorder or vice versa. However, there are instances where we can see a clear correlation.
Sure, yes. Bullying can be a big pathognomonic symptom of possibly having one of the disruptive behavior disorders. So that's what we look for. And we typically ask parents if they've seen or experienced reports of that in their children. So that's one of the things that, parents or counselors or treating providers can kind of look at to see if there has been an issue with bullying in the past.
Yes, that's very important. And we also want everyone to understand that there are actually two different disruptive disorders that are in the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders. The first is oppositional defiant disorder, and then the other is conduct disorder. Now, ADHD was previously in this category, but it was moved into a different category, which is now called a neurobehavioral disorder. So that's no longer in the class of disruptive disorders. So that's been a big shift in the field within the last couple of years. And if anyone's interested in learning more about ADHD, I recommend you check out Psych Sessions episode number 14, where you can hear an entire show on that subject. But historically, there has been a high number of children who've been misdiagnosed with ADHD. So hopefully moving it out of the category of disruptive disorders will help with better recognizing the symptoms in order to accurately diagnose and treat ADHD.
ADHD and especially ODD have a high co-occurrence. So ADHD children often have an irritable temperament or poor frustration tolerance, and coupled with some of the environmental responses, so harsh parenting or difficult situations, a child who is ADHD alone can develop a worsening case of opposition and actually develop an oppositional disorder due to the environmental pressures and how those situations are handled with parenting. And a lot of times, especially in the school situation, a child with ADHD gets very frustrated. They don't necessarily grasp things as quickly. They might need more breaks. And if those things aren't really wrapped around and provided for the child, they really do have a hard time and get more rebellious in terms of completing the work or being in a structured environment. And that can lead to symptoms of oppositional defiant disorder. And if not addressed and treated, that can then lead to conduct symptoms where they start being truant from school, start hanging out with the wrong crowd, and lead to possibly substance abuse or early sexual behavior. So these can occur on a continuum, but depending on where the interventions and how the situations are handled, that is when the disorders can develop.
So let's help our listeners understand a little bit more about the symptoms specifically of a disruptive disorder. Let's share some of those.
It's interesting because these disorders are consistent with behaviors that you might see in normal development. However, the symptoms of an actual disruptive disorder they're more pervasive and they last a little longer and they're more severe than you would see in a typical developing child. So some of the symptoms you might see are defying authority or multiple angry outbursts or lying or stealing. And it can, if in conduct disorder, they can be worsening behaviors such as being physically or verbally aggressive. They could be, basically destroying property or harming animals. So depending on which disorder you're talking about, the symptoms are kind of on a spectrum and they can be more and more serious depending on the disorder.
Yes, and it's also important to note when we talk about disruptive behavior disorders, we see a connection with the behavior being directed towards an authority figure. And this is another thing that makes this disorder stick out, that it's not something that may stand out amongst their peers. It's not about their interpersonal style with their peer group. It's exhibited in their irritability and defiance with those in positions of authority over them. And along the lines of peer groups, whether we're talking about school or extracurricular activities, we will often see a level of normal, what we would call normal childhood rebellion. But that's not what we're talking about here. Let's go in a little more detail about how these symptoms are different than normal childhood rebellion.
It's the persistence of the symptoms as well as the harmfulness. So these symptoms in typical childhood, they're going to test their limits. They're going to see where the boundaries are. They're going to see how far they can go. And they're going to respond with anger or even aggression at times, depending on the situation. But children without a disruptive disorder typically respond to consequences. They respond to education, or when you look at the situation and try to give them some feedback, they generally respond and they show remorse. So with the disruptive behavior disorder, they commonly don't respond to consequences. You can punish them, you can, give them detention, you can suspensions, escalating signs of consequences, and they just don't respond. And with conduct disorder, they might even interact with the legal system. So, they might have truant behavior where they go to a program through the juvenile courts or even incarceration due to their symptoms, and they still are persistent and rebellious and refuse to adhere to these social norms, as opposed to normal childhood rebellion or typical childhood rebellion. Once they get those heavy consequences, they tend to kind of fall in line or at least reduce their reactivity.
Hey everybody, I hope you're enjoying this session. I want to invite you to download your free tip sheet on disruptive behavior disorders at psychsessions.com. It lists some things that can be helpful if you have a child or you know a child who's been diagnosed with a disruptive behavior disorder. That free tip sheet is available at psychsessions.com. Just look under the show notes for this episode, which is number 38. You know, Dr. Gathing, you are so right, and it is important for our listeners to understand the principles that we're talking about, especially parental figures and those in positions of authority as well, because if you see these types of behaviors and you respond in a way that is more authoritarian or overreact instead of approaching it with more of a balance, even if you have the best of intentions, if you do not handle the situation correctly, your efforts can actually exacerbate the problem.
Oh, sure. And you used one of the key words. You can tell you're in this field. Authoritarian parenting has been one of the styles characterized by having those high demands, but that low responsiveness to the emotional needs of the child. And so it's brought up a lot in the field as the parenting style that has a lot of issues with developing defiance in children. So these parents have these high expectations of their children, but provide little feedback or nurturing for these behaviors, and they don't always give good responses to positive behaviors or reinforce those positive behaviors. And they really pay a lot of attention to or call out those negative behaviors. And that can lead to a whole cycle of worsening negative behaviors. So, authoritarian parenting is definitely one of the ones we try to coach parents on trying to stay away from or minimize those responses.
Yes. And another important point to highlight is something that I've mentioned repeatedly on this show, which is the importance of only a licensed mental health professional making a diagnosis, whether it is for disruptive behavior disorders or for any disorder for that matter. And that is not only the ethical thing to do, but it's also in the best interest of the child. So I ask the listeners to keep in mind that many of the symptoms that define what we're talking about, be it disruptive behavior disorder or impulse control, conduct disorder, these are behaviors that can occur to some degree in typical development. And that's why it's really critical that a clinician take a look at the frequency, the persistence, the pervasiveness across situations, the impairment that's associated with the behaviors, cultural considerations, the individual's age, their gender. All of this has got to be taken into consideration when determining if they are symptomatic of a disorder.
Yes, I think that is really important because in our society, especially with the internet and with all this access to information, we really feel armed with enough information as lay people to make some of these calls, especially with symptoms of ADHD or behavior disorders, that you are looking at behavior to make the diagnosis. So a lot of people feel like, oh, I can make this call. But what they don't understand is that as licensed professionals, we're looking at a broad spectrum. We're ruling out medical disorders. We're ruling out other mental health disorders that you might need to have more investigation, or like depression or anxiety that can mimic some of the symptoms of behavior disorders. So I think it's really important to realize that the teachers and administrators and parents and guardians are our first line, and they're typically the people we get our information from. So we don't want them to just throw their hands up and say, okay, this has nothing to do with me. We want them to be our partners in making these diagnoses and developing treatment plans and differential diagnoses. But it's important to remember that they don't have the skill set of making sure to rule out something more serious and something else that may need a different level of attention or treatment by minimizing it as just a behavior disorder, or escalating something that may be a response to another condition and saying, that this is a behavior disorder when there's other things going on or co-occurring. So I think the important thing is to remember that in mental health, we're trained and licensed to look at a whole person and look at a whole treatment plan. So we want to make sure that people that are licensed to do that are the ones that you're taking your cues from.
Absolutely. Well, earlier we touched on how ADHD has been moved into a separate category. What other changes have been made to the area of disruptive behavior disorders?
Yes, this is actually a pretty fascinating change with DSM-5. They have lumped together the disruptive disorders with other impulse control disorders. So the category is now disruptive impulse control and conduct disorders. So they have looked, in the science of all of these disorders in this category are that they have the issues with behavioral and emotional control. So regulating the behaviors and emotions. And that also includes impulsive control disorders, which used to be in a totally different category. So it looks like they've really found a common thread between some of these disorders. So they put them together. So I really thought that was an interesting choice, because there were disorders like intermittent explosive disorder or impulse control disorder that were in a separate category, but they finally found kind of that common thread that these children and sometimes adults have issues with regulating their behavior and regulating their emotions, and that's what leads to a myriad of other issues. So that's one of the bigger changes that's happened with the DSM-5.
Yes, and we know that this can be an issue moving into adulthood as well.
They used to have criteria that says these are things that had to be diagnosed in childhood, but they've relieved that a little bit, because now we know that, there's some families or some scenarios that people are in where the behavior has not been described or diagnosed, like we said, by a professional. So people might have known they had an issue, or especially the parents or family members, but it hadn't been formally diagnosed. So when they become an adult and you're looking at the total person, you want to get a good history of childhood behavior. And so then it can be diagnosed in adulthood. But generally, by the time they're adults, the disruptive behavior disorders have either been treated or naturally remitted, or have transitioned to what we call antisocial personality disorder, which is now you look at these behavior disorders and they become a part of how that person functions on a day-to-day basis. And it's not just triggers, or it's not just scenario, it's been incorporated to how they look at the world, how they view the world. And so as an adult, these symptoms have often either deteriorated, worsened, or transitioned to antisocial personality disorder.
Yes, and I'd emphasize that while, as we said earlier, we don't want to overreact or be authoritarian in our style or exacerbate the problem, we don't want to minimize it either. Because if there's a lack of intervention or treatment, there is the chance that this could be seen in antisocial personality disorder, which could be much more dangerous not only to society, but to the individual themselves.
For sure. And that is why I think it is so important not to overlook some of these things. As a treatment provider, I say, bring them to us. Let us see what's going on. At the very least, we have some good tips for you on how to parent your normally developing child, or typical child, and worst case scenario, we develop an intervention that can protect them from developing or worsening problems later. So I always urge my families, if you're concerned, bring them on in. Just let us give you the opinion. We might be
Right.
signing off and saying, oh no, you're worried about things that are typical behavior, or we might say this is normal behavior, but here's some strategies. Or we might say, no, this really does look pathognomonic for a disorder, so we're going to develop a treatment plan, because we don't want them to develop a worsening disorder. As ADD can transition, like we said, to ODD or be comorbid, and ODD, if not treated, definitely has a high percentage that can lead to conduct disorder, which is worsening symptoms. So we do want to intervene as early as possible and at the lowest severity possible.
Hey everybody, it's Jimmy. If you'd like to learn more about today's topic, head on over to psychsessions.com, where you can download your free tip sheet on disruptive behavior disorders. It's got some things that are helpful to understand what to do when a child has been diagnosed with a disruptive behavior disorder. That free tip sheet's available at psychsessions.com. As we continue talking about disruptive behavior disorders, we know that it's something that spans across all the different socioeconomic backgrounds, races, ethnicities, etc. But we don't really have a firm idea or handle on just how many children have the disorder.
So this is where things get tricky, because when they do the sampling, sometimes there's either an oversampling, meaning you're looking at a population that's higher risk, where the numbers may be skewed, or they're low risk and it's a screening or preventative situation where it might underskew the numbers. So the range out there of total disruptive behavior disorders is generally about 5 to 14%, which I know is a big, broad number. But when you break it down to ODD versus conduct disorder, you get some better numbers. So ODD is typically about 8 to 10% of your population, and conduct disorder is about 4 to 6%. So generally, these are disorders that are present and they are there, and it's almost as high as some of the studies of ADHD. So you want to definitely not ignore those signs if you see them.
And I also want to make sure that my listeners understand that research and empirical results clearly show that conduct disorder is a more extreme condition than oppositional defiant disorder.
Oh, for sure. Conduct disorder is a more severe disorder. It has a part of it where they have to be violating the rights of others. So they have to be harming others or threatening to others in some way. So they're destroying property, or they're getting into fights, or they're stealing things, or, being very manipulative, lying. So, conduct disorder is a disorder where you do want to make sure that you intervene early so that these behaviors don't worsen and get to the point where they are breaking the law or getting into the juvenile justice system, as it is a disorder that is characterized by higher levels of aggression.
Right, and as we talk about higher levels of aggression, I'm thinking about a news story that I saw recently where an adolescent had harmed a dog, a small dog, and it was really not only sad but very disturbing to see the severe nature of the abuse that this child had imposed on this defenseless animal. And it is a sign that we need to be aware of. Not that I would make a diagnosis based upon an isolated act, but it's something, again, that can be a warning sign, and we need to make sure that this individual gets help so that we don't continue to see a pattern of destructive behavior, be it towards people's property or other individuals.
So once you see harming of animals or destruction of property or any of those things where the child or adolescent is harming another person, then you do definitely want to make sure to have them evaluated. And like you said, it might just be a singular situation. Maybe they were in fear. Maybe the dog had harmed them or threatened them, or maybe they had a bad incident with an animal in the past and had some anxiety and handled it in a negative or incorrect way. But you don't want to just take a snapshot. But that is one of the symptoms that is more highly at risk for having conduct disorder, having danger or harm to animals.
Well, what other issues do children with disruptive behavior disorders generally have?
Yeah, that is a great question. And I need to, and I know a lot of people say don't separate children by sex, but it's important to remember that these issues present differently in females and males. So with your males, you're going to see more of the fighting, the stealing. They might vandalize things. They might have school discipline problems. In our females, you might see more issues with running away, early substance use, early sex or prostitution. They're less likely to exhibit those physical and verbal aggressive symptoms. They can, and they do, but sometimes they present in a more atypical nature with lying or being truant and running away. So you definitely want to look out for some of those problems as well. And then, these children, like others, they often have other mental health issues. So many of them, like we talked about, have ADHD, they have mood disorders. Many of them have been found to be suicidal or anxious. So you want to make sure that you get them fully evaluated for the full spectrum of mental health disorders.
Absolutely. Some important considerations for us. And we're not only concerned with a child's outward aggression, but for aggression that is directed inwardly as well. And we can see this manifest through self injury or self harming behaviors, which I discuss in episode 29.
Sure. We see a lot of our, especially females, who have that self-injurious behavior or suicidal ideation. Males as well. And males actually do have a high level of mood disorders, especially depression with conduct and ODD. But many times the females are who have the self-injurious behavior.
Let's talk a little about the difference between a disruptive mood dysregulation disorder and a disruptive disorder.
Disruptive mood dysregulation disorder is a newer diagnosis. This is one that has just been developed and is new with the DSM-5. So a disruptive mood dysregulation disorder is really focused on the mood. So they have neurovegetative symptoms of depression, such as not caring, being sad, and they also have this highly irritable nature or temperament. So they're constantly irritable or angry or frustrated, and they have these temper tantrums or anxiety episodes that last for hours at a time. So their mood regulation issues are a lot more severe than those you see in ODD or conduct disorder. And often it's not in response to anything in particular. I've had children who say they woke up and they just woke up on the wrong side of the bed or just were angry with nothing going on, no problems. It was really just their internal mood that was driving their negative behavior and perceptions. So the difference, I would say, in disruptive mood dysregulation disorder and disruptive disorders is this focus on the irritability and negative internal sense of emotion as opposed to regulating their emotions.
Well, we briefly touched on some of the other disorders that can be somewhat similar to a disruptive behavior disorder, but what are some of the other disorders that can look like a disruptive disorder?
No, I'm glad you asked it in that way, as that can be a little bit different than what other problems can they have. So the number one problem I see that some people overlook is anxiety disorders, especially social phobias or generalized anxiety, as that can present with school refusal and truancy issues. A lot of anxious children and teenagers have not been diagnosed, so people don't really understand how hard it is for them to function in a social or educational environment. And that can lead to problematic externalizing behaviors, such as refusing to participate in activities, refusing to go to school, and really wanting to be on their own or even use substances to help them with their feelings. And similarly with depression, depression is really a major disorder that can look like a behavioral problem in a younger person who doesn't know how to express their feelings or tell you how they feel. And they kind of have acting out behavior that's coming from how they feel on the inside. So I think those two are really some of the ones we see that can present with behavior issues, but if treated effectively, some of those behaviors decline, as well as substance use. When someone is using substances or coming down off substances or attempting to obtain substances, they can present with a lot of externalizing behavior issues.
Well, we know that there's no isolated gene or single cause for a disruptive behavior disorder, but what do we know through research with regards to causation?
For ODD as well as conduct, they're both multifactorial in origin. So for ODD, there have been many research studies that show that a child's temperament or how their natural mood patterns of development contribute to oppositional behavior, and including, poor emotional regulation or high levels of emotional reactivity and poor frustration tolerance. So that kind of leads to this high risk of ODD. And also, like we talked about, the environmental risk factors. So the harsh or neglectful parenting, that highly authoritarian parenting can definitely contribute. And for conduct disorder, there's been some fascinating research on their brain functioning. So a lot of these children don't develop typical brain patterns as other children, and they have issues in the brain areas that regulate behavior and impulse control. So they have shown on CT scans or MRIs that they have lower reactivity to danger and lower emotional responses to certain things that you might scare you or I. So they have different patterns of behavior when confronted with situations, and that's been shown on brain scans and studies. And they know that there's genetic vulnerability as well with conduct disorder. So they've seen it in families and spectrums of families, especially, ones with alcohol dependence or abuse in their families. So, again, it's multifactorial, but there are some patterns that we do see.
Yes, and we also know that a child is more likely to have a conduct disorder if they have a family member with depression, anxiety, or a learning disorder.
Yes, correct. So families where mood disorders like depression and bipolar disorder, they have a higher likelihood, and anxiety in their family. And it's interesting because those families can typically have a issue with childhood abuse or neglect as well, because they have depressed parents or have parents with mental health issues, which child abuse and neglect can also reinforce or be high risk for these behaviors. So again, looking at the full spectrum of behavior, parenting, and genes, kind of help us put it together.
Well, we know that conduct disorder can be treated effectively, and no one form of treatment is best for any individual. Again, it's important to remember to treat the individual, not the diagnosis. But give us an idea of what your treatment approach is like.
Right. So this is what I do, and you'll read a lot that says for conduct disorder, there's not much you can do, or but that just is not true. So nowadays we know that you just have to take a multifactorial approach, as a lot of times there's a multifactorial origin. So we use individual therapy. So we help the child develop more effective coping and problem solving skills and help them figure out ways to express and control their anger. And we also couple that with family therapy, where we help the family interact and communicate amongst themselves. And we also, which is very important, is parent management. So we take the parent separate from the child and talk to them and help them develop strategies on responding to their child's behavior, coping with their child's behavior, and teach them how to positively reinforce behaviors that they want to see and give consequences or negative behaviors for the ones that they don't. So really teaching the parents how to jump in there and respond in ways that would likely help their child learn how to regulate their emotions.
And that's something that I certainly try and help parents to develop more of, that opportunity to be able to use positive reinforcement. And while medication may be necessary eventually, not to be so quick to turn to psychotropic medication as an intervention.
And you notice I did not talk about medication, which is always my second question they ask are, is there going to be a medication for this?
That was a follow-up.
Was that one of the things you were going to ask?
I'm very interested in hearing your thoughts on that.
So my thought is, if you fully evaluated the child and have not found any co-occurring disorders that need to be treated with medication, such as depression, anxiety, those do need to be treated. ADHD, those all have medication interventions that have been proven to be effective. But if you have really genuinely ruled out those co-occurring disorders, ODD and conduct have not been shown to respond to medications. And so really first line is these therapies and reteaching these families how to interact with each other and communicate. It's really a hallmark, because if you give a child a medication and it does work, it's likely because it's sedating the child or slowing him down and not teaching them the new tools and new ways to interact and engage. So as soon as you take that medication away, they're still in that same environment and still have the same perception of the world and ways of interacting. So you really have not led to an effective treatment. You've really just either dulled them or sedated them or taught them that being tired or not really focused on the problem is the key, which you don't want to reinforce.
I certainly encourage a balanced approach to psychotherapy to include medication when necessary, but we just have to be aware of ensuring that medication does not perpetuate the problem, and also make sure that we're looking out for any of the side effects that are associated with the drug. So I certainly agree making that decision on a case-by-case basis. As we start to come to a close, let's take a look at the prognosis of disruptive behavior disorder.
So this is interesting because, as we talked about, some of the disorders do, without intervention, have a higher likelihood of developing a worsening disorder. So with treatment and early intervention, these disorders have a great prognosis. So they do improve. The children and adolescents go on to have normalized behavior and development. But the earlier onset of the problems, the more intervention they're going to need and the more time you're going to need to pay attention to these disorders. So earlier intervention, the earliest possible, is key. And, some of the protective factors are those positive relationships and getting involved in pro-social activities such as sports teams and things like that. So when they get normalized behavior all around them, they do tend to improve. So these are not disorders that are hopeless, Right. This isn't something that's a life sentence. This is just something that's going to take a lot of patience, a lot of thoughtfulness, but they do have a really good prognosis when treated.
And that's really encouraging for everyone to understand. Well, Dr. Gathing, what closing thoughts would you like to share?
Well, I think we really discussed most things, I would say, but I want to tell parents and especially mental health professionals that none of this is easy, but really they need consistency and love. And if you give that and you give your attention and really are consistent and stick with it, this population can be won over and improved. And, that's why I do the work that I do, and I'm inspired to help others work with this population.
Dr. Gathing, thank you for the work that you're doing. It's always good to talk with friends, and I want you to know how much I appreciate you helping me to help others. Thanks for being on Psych Sessions.
Thank you for having me. I enjoyed it.
Well, thanks for joining me today, everybody, and don't forget to head over to the website and download your free tip sheet on disruptive behavior disorders. If you enjoy Psych Sessions, I've made it easy for you to partner with me in helping others. Before you make your next purchase on Amazon, go to psychsessions.com and use the affiliate link on the homepage. It doesn't cost you anything extra, and it's a simple way to support the show and helps me help others. So thanks in advance for participating with me as I continue serving others. And lastly, thanks to all of the parents and the teachers for your feedback about how the show helps you, your children, and your students. It's a joy to know that Psych Sessions is making a difference in your lives. Well, thanks again, everyone. I'm Jimmy Morris, and I look forward to speaking with you again next time on Psych Sessions.